Today I'm going to talk to you about forward-backward practice. For example, we have myasthenia gravis. So for myasthenia gravis, when we do inspection, what you will see is perhaps ptosis. When you examine the tone of the upper limb, normal or reduced tone, then when you check the power, you will have proximal weakness, proximal weakness. And then when you check reflexes, it will be normal. So as sensory will be normal as well. Proprioception will be normal. And then cerebellar will be normal. Okay. Then what you will do in addition is you will proceed. Myasthenia gravis is when someone have a proximal weakness and ptosis, you would like to check for fatigability. So where do you check for fatigability? You examine the upper limb, proximal upper limb, the eyes, and then listen to the speech. So other things you proceed or look for, after that you know that this is likely an MG, then what do you do next? You examine the treatment-related sign. So what are the treatments related signs?
Yes, signs of immunosuppression, steroid like Cushing faces or
You look for a scar, right? For thoracotomy scar, for thymectomy. You think about a diagnosis, then you try to imagine what are the signs. What is backward formulation is from that sign. Now you try and figure out what are the differential that you can get and what are the things that you should look for. What are your differential? When we think about a case like this, we have to consider proximal weakness, right? If it's proximal weakness, can it be upper motor neuron?
Motor neuron will be like, is it like the myelopathy?
Yeah, we are just doing the revision of last class. Cervical, cervical myelopathy or sphingomyelia, At what level? Cervical myelopathy at what level?
C5, C6.
What else? Can it be low motor neuron?
Can at the NMJ, muscle level and the nerve level.
When you think about MG and you come up with all the signs, doesn't mean these signs are only for myasthenia gravis. It can be for any other differential that you have listed down. All right, and therefore it's important to proceed and differentiate whether they are, which one it is. So for example, if when you do reflexes if it's reduced or absent areflexia, then you're thinking about neuropathy, and the reflexes is normal, then you think of muscle or
okay, MG. Yeah.
Then when you check the sensations, sensory, there is absent sensory in the distal neuropathy. When the sensory loss is in the proximal, what is it likely to be? Finals, C56 dermatomes. These are C56 dermatomal loss. Or sensory examination is normal. Then what can it be?
Muscle.
And
MG.
if the sensory is normal, the reflexes are normal, what do you do next?
Do the fatigability test.
When you come to this point, what you are doing here is whatever you are doing exactly the same. So this is called forward-backward analysis. When you have a diagnosis in mind, you need to do further steps to confirm your sign. Do you know how to do fatigability examination for upper limb?
First, for the speech, we ask the patient to count from 1 to 0, the reduction in the speech and the volume.
What kind of speech is that?
Nasal speech or what? The eye, is there any ptosis with fatigability?
Yeah, how do you check that? So for fatigability, what you do is you use a torch, shine with a torch and from the lateral upper angle. So patient is looking up and laterally to a light torch. Because our eyes will get tired easily when we are looking at a light torch or a light source. And then when we are looking up and laterally, there's the positions that we'll feel very tired easily. But what is more important if this is upper limb examination? So the first thing you want to demonstrate is upper limb fatigability. So first examine both sides, examine both sides. Then exercise one side, Then examine both sides again, The reason why you are doing this is so that you can make a comparison between the left and the right, or between the side you exercise and the side you didn't. So afterwards, you will go back, examine the scar for thymectomy, and look for cushingoid features. So in the Myasthenia Gravis, there are 4 systems that will be affected. So the first one is muscle. The second one is the speech or swallowing. Patient will have dysphagia. So we call this bulbar component, bulbar system. So the muscle, the bulbar system, ocular muscles, respiratory. So in fact, at the end of the day, the one that decide whether you want to ventilate or whether patient got myasthenia crisis is the respiratory system. This 40-year-old lady noted to have ptosis, and on examination of the upper limb, the tone was normal. Power was proximal 3/5, distal 5/5, and the reflexes and sensations were both normal. Perception and cerebellar were normal as well. On further assessments, the patient was noted to have fatigability of the upper limb as well as fatigability of the ocular muscles and the speech, which was nasal in nature. Further assessments show that patients appear to be cushingoid, possibly related to steroid treatment, and there were thymectomy scar noted. So the diagnosis of this patient is myasthenia gravis, and she was treated with steroid and previous thymectomy, and currently having proximal weakness and fatigability. So in some patients, they may have central line for plasma exchange. We can also mention about that. So let's look at the case from another perspective. You can be asked to examine the cranial nerve or look at proceed. This patient have leftosis. When you inspect and you found to have leftosis, what should be done next? The first thing is to examine the pupils. If the pupil is constricted, then you should think about Horner syndrome. If the pupil is dilated, then this will be a third cranial nerve palsy. Or if the pupil is normal, then this can be either a third nerve palsy without dilated pupil or a polyneuropathy, like in Miller-Fisher syndrome, or it can be a muscle or myopathy, or it can be a neuromuscular junction disorder like myasthenia gravis. So if the pupil is normal, the things you should examine next will be looking for ocular muscle movement or ophthalmoplegia. And after confirm that this is a third nerve palsy, you should first further confirm whether there are 4 and 6 nerve palsy as well. If it's isolated third nerve, then the approach will be slightly different from a complete ophthalmoplegia. If the ocular muscle, ocular movements are normal, then you should think or you should proceed to assess for ocular fatigability. Mainly aim to finish all the steps related to eye examination. Whereas for polyneuropathy and myopathy, you need to examine other systems to confirm the diagnosis. All right, and because of this, there are three different scenarios. Okay, so the first scenario will be myasthenia gravis. So as you can see here, if the patient, as you can see here, if the patient have left ptosis without ophthalmoplegia and there were ocular fatigability, then you should examine the bulbar system and later on assess the upper limb for proximal weakness and fatigability, and then examine the chest for scar as what we have described just now. If the instructions is to examine the cranial nerve, then you should complete the full set of cranial nerve examination from cranial nerve 2 to 12. The second scenario will be unilateral third nerve palsy. All right. And you examine the 4 and 6, which were normal. What you should do next is to examine the cranial nerve. And if they are all normal as well, then you should examine the upper limb for power and cerebellar sign. Sometimes you examine the sensation if you have more time, mainly because isolated third nerve, there are two key differential. One is mononeuropathy, like in diabetes or mononeuritis multiplex, or it can be a midbrain lesion. All right. However, if the 4th and 6th nerve are abnormal, then our diagnosis will be a complete ophthalmoplegia. Then we should examine further for other cranial nerve, mainly the 5th nerve, the 2nd nerve, and the 7th nerve. Just remember, 3, 4, and 6 started in the brainstem. So this is a brainstem and reach the eye through different pathway. So first they leave the brainstem. So this is the first possible anatomical lesion. Then they came across cavernous sinus, go through the superior orbital fissure, and then reach the retroorbital space. Retroorbital space. Before they supply or attach to the eyes. And along this lesion, the 5th nerve, the 2nd nerve, and sometimes the 7th nerve are associated with the 3, 4, and 6 abnormality or palsy. The third scenario will be a left, but perhaps left more than right ptosis or bilateral ptosis. Then we should consider whether this is a neuropathy or this is a myopathy. So first, you want to examine other cranial nerve involved in the polyneuropathy or myopathy, especially cranial nerve 7 and bulbar for bulbar weakness as well. After you have finished the cranial nerve examination, then you examine the upper limb, mainly looking for weakness, especially proximal weakness or aphyxia, which will differentiate whether this is myopathy or neuropathy. So let's now make presentations. For example, we have a unilateral third nerve palsy, and there is a contralateral limb weakness and due to midbrain syndrome secondary to stroke. So this is how I will present. So this 40 years old female was noted to have left ptosis associated with a dilated pupils, and there were restrictions to the upward and medial gaze, indicating a complete third nerve palsy. There were no fourth and sixth nerve involvement, and other cranial nerve were normal. On further examination of the upper limb, there were right-sided hemiparesis. Therefore, the lesion is likely at the left midbrain, and the likely etiology is stroke. We can also try another case scenario, which is a unilateral complete ophthalmoplegia. So this is how I will present. So this patient was noted to have left ptosis associated with dilated pupil and complete ophthalmoplegia with restriction of gaze in all directions at the left eye. The first branch of the trigeminal nerve was involved with reduced sensations over the forehead. However, other cranial nerves were normal, including second and the seventh nerves. Therefore, I think the lesion is likely in the cavernous sinus or the superior orbital fissure, and the common etiology for cavernous sinus lesion will be cavernous sinus thrombosis, whereas for superior orbital fissure will be a mitotic lesion or primary brain tumor or granuloma.